Okay. Hi, everyone. Good evening. I'm Steve Ambler. I'm just going to make a couple of announcements, and then we'll get things quickly over here to Dr. Sahrmann. So thanks for coming to celebrate Founders Day with APTA Missouri. I do want to just remind everyone that about 15 minutes after we finish our Missouri event, you can attend the live APTA event. I'm just putting the link for that in the chat right now. And that's live stream, no registration necessary on all of APTA's social media accounts and YouTube. We have 2 recordings going tonight. So hopefully this recording will be available for you and anyone who's not able to attend this evening. Just one logistical point is that we've asked Dr. Sahrmann to give her full presentation first, and then we will take questions both by unmuting and in the chat, and I'll help her monitor the questions in the chat at that point. But I'll probably not interrupt her in the middle for any of your chat questions as we go along. Okay, and then the only other thing I want to do is just take pleasure in introducing Dr. Sahrmann, someone who's been a mentor and friend for me. So this is a very compressed bio, as those of you that know Shirley would expect. So I can only just touch on a few amazing things that she's done through her career, but I'll try to give you the gist. Dr. Sahrmann is Professor Emerita of Physical Therapy at Washington University School of Medicine here in St. Louis. She received her bachelor's degree in physical therapy, master's and doctorate degrees in neurobiology, also from Washington University. She's a Catherine Worthingham Fellow of the APTA and is a recipient of the association's Marion Williams Research Award, the Lucy Blair Service Award, and the Kindle Practice Award. Also, the John H.P. Maley Lecture, I believe it was the inaugural lecture for that one, and the Mary McMillan Lecture Awards. Dr. Sahrmann has also received Washington University's Distinguished Faculty Award, the School of Medicine's inaugural Distinguished Clinician Award here at Washington University, and an honorary doctorate from the University of Indianapolis. She has also received the Bowling Earhart Orthopedic Clinical Practice Award from the orthopedic section of the APTA, and has served on the APTA Board of Directors and as a past president of our Missouri chapter. In addition to her numerous international presentations, Dr. Sahrmann has been a keynote speaker at the World Confederation of Physical Therapy, the Canadian, Australian, New Zealand, Japan, and Danish national congresses. Dr. Sahrmann's research interests are in development and validation of classification systems for movement system impairment syndromes, as well as in interventions for these syndromes. Her books, Diagnosis and Treatment of Movement Impairment Syndromes and Movement System Impairment Syndromes of the Cervical and Thoracic Spine and Extremities, describe these syndromes and methods of treatment. So Shirley, thanks so much for being here, and please take us away.
Oh, thank you, Steve, for this opportunity to share all these years. I do think, by way of perspective, it's important to note that it was a lot easier to get awards when there were only 100 people in the association. It's much more challenging these days. So I want to talk about my trip and where I think you people will be taking the profession with a few suggestions. So my purpose is going to be review our accomplishments, talk about some incomplete actions, the effect of tradition, and I can't help myself but propose additional steps for consideration. I want to convey how physical therapy has really progressed during my 64 years in the profession. It's been an amazing journey that started out, believe it or not, as a technician following the treatment prescription from a doctor for conditions induced by an acute pathology, and has progressed over all these years to being part of a doctoring profession, diagnosing conditions of a body system that's consistent with our expertise. And also recognizing the role of movement in causing or contributing to lifestyle-related chronic health conditions. And I really want to emphasize this. And yes, we can also provide effective treatment for these movement-related problems. I want to try to tie in the factors of the roles of the association and societal actions that have been behind all this, as well as the many positive and then even some of the negative aspects of tradition that have affected us both internally and externally, and to suggest additional actions to further raise the status and recognition of this great profession. Believe it or not, I really wasn't here for the first part. Happily, you can't see me, or you thought I might be. But anyway, the years between 21 and 56 were really because they needed to fill a need created by both world wars as well as by polio. There was some treatment of patients that were cerebral palsy, but not too many of what we call neurological patients these days. All these people were putting the elements of the profession in place, developing this professional organization, and then establishing educational standards. And education itself progressed from a hospital-based one to university degrees. And programs went from certificates to BS degrees. In fact, when I came in, I was very impressed because the maturity of many of the clinicians, many of them had actually been in the military, or they'd been nurses or physical education teachers prior to becoming physical therapists. And they were quite an impressive bunch that had done amazing things for getting this profession started. So then I'll pick up in the middle 1950s, because this is when I started to school, and then to the early 1960s. And what I'm going to be trying to do as we go through this, and if you can see it, is kind of balance profit with quality and talk about the changes as we went through the years. And I'm going to highlight for these years that we went from being technicians to professionals. That was according to the Department of Labor. And we had a big change in patient conditions that have really had an impact over all these years. And one of those impacts was the emergence of named treatment systems. And then to fill in the details, and it'd be hard for you people of today to realize what things were really like in the 1950s. The students were much younger. That was kind of a change from the therapist I had encountered, but because we went to this baccalaureate degree, most of the students had 2 years of university and then went into the PT program. Many of them were actually pursuing an MRS degree. In other words, they were looking for a doctor, really no thought of getting a doctorate themselves. And they were really rather sedentary, which is such a contrast to today. In fact, I remember one incident of having to do 10 straight leg raises, and 3 of my classmates couldn't come to school the next day because they were too sore. And PT was considered sort of a short-term job. It would be a nice thing to do until you got married, and everything was kind of, and I don't mean this in a derogatory way at all, about being a Susie homemaker. But then in 1954, we started to pursue state licensure. And I remember working on it for the state of Missouri, and we actually, believe it or not, tried to set it up so that physicians would refer patients, because we thought that would give us credibility. And believe it or not, it took until 2003 before the last state finally got licensure, and that state was Kansas, a neighbor. Education was really very basic. The education was described by courses you took, not by the outcome product. So you had to take anatomy, and in fact, and then you had to take anatomy, and then you had to take anatomy, because we didn't have all those other things to teach. In fact, I spent so many hours in the anatomy lab, I thought I was not sure I would ever smell right again. And we didn't use gloves, so I thought my hands were forever preserved. The faculty was really kind of non-academic. There was an old saying at the time that said, if you can't practice, you teach. Quite a contrast to what we have today. And I do believe the faculty was about 1 chapter ahead of the students. Practice itself was primarily in the hospital and in rehabilitation centers. And it was kind of interesting because actually rehabilitation centers would run mini educational programs once they hired their therapists. In the 1950s, there had been this big surge of of polio patients. In fact, though this virus is something that scares you now, but I remember being very scared that I was going to catch polio as well. In fact, still have hesitancy to swim because of all of this. And then in 1955, right as I was entering physical therapy school, the Salk vaccine came out and the polio patients went away. But what's important to know about all that, I still saw some polio patients and I still saw the residuals of polio. And that was a really wonderful way to get started because things were much clearer. We knew what the problem was. The patients lost their muscles because they lost their innervation, and they developed contractures because muscles were unopposed and they would pull the joints into bad positions. But what was particularly good, with all the attention that physical therapy got because of our Franklin Delano Roosevelt being afflicted by polio, was that we did such a good job that they started allowing us to see stroke patients and more about cerebral palsy patients because we had made an impact with the treatment of polio patients. But there was this big change from the lower motor neuron problems to the upper neuron problems. And that was really hard to take because I couldn't stretch patients anymore because I'd make their spasticity worse, and I couldn't strengthen them because I'd make their spasticity worse. And I really didn't know what in the world I should do with all of these patients because all the things I had learned to do, I wasn't supposed to do anymore. But I was trying to make some decisions, and I was part of a study where the Department of Labor sent people to come in and they watched us work and they said, oh, you make decisions, you must be professionals. Oh, well, I thought that was a good idea myself, and so did everybody else. So no longer were we classified as technicians, we were now classified as professionals. The other thing that changed, and that's because we didn't understand these upper motor neuron problems, is the treatment changed from dealing with the identified manifestations of a pathological problem to name treatment systems. So we had the Bobath approach, we had the Rude approach, we had the Brunstrom approach, we had PNF, and those were all getting a start. Clearly the Bobaths were out there and PNF was out there ahead of time. But continuing education wasn't like it is now. So you heard about little pieces, but not very much. So then we go on to the middle 60s to the early 70s. And so if you can see my little balance scale here, profit got better because of the Medicare came in. So we became income producing. Also, there was some little hints that lifestyle could be related to health. The other thing, and I do think this was a big thing, was women's rights, and women started thinking more about careers. Not a lot, but a little bit. And the MD prescription, before they laid out very specifically what to do, became a referral because they couldn't tell us what to do with the neurological patients because they really didn't know. There was still a tendency to write a very specific prescription for musculoskeletal patients. So the details are, in the 1960s, the membership of the association was about 15,000 people, and educational programs, 52. And the reason why I say we began to relate it to health is because it was 1964 that smoking was identified as a cause of cancer, also the year of my last cigarette. Before then, I wouldn't even want to tell you what it was like. It was horrible. Anyway, so a little hint that lifestyle had something to do with your health. And then 1965 was the real biggie, the introduction of Medicare and pay for procedures, which is what the AMA insisted that Johnson do for their approval. And it really brought about a big change. Before, I would see patients and they would be on 20-bed wards separated by curtains, one for general medicine, one for general surgery. And then Medicare came in and suddenly we were in 4-bedded rooms. Things changed. The other thing that was important, and I put it down here, is because seatbelts became mandatory in 68 and in 69 headrests. And that was a really good thing because many of those neurological patients were men that were 6 foot tall, because if they were rear-ended in a car, they became quadriplegic. We had lots of quadriplegics, and they were beginning to save the lives of the head injured and the quadriplegic. And then in 68, also the women's liberation movement started. I think one of the funny things, and tells you how we're not quite there yet, is that it was in 1972 that the Equal Rights Amendment was passed by the Senate, but it still hasn't been ratified by enough states to be part of our laws. And Title IX started. This was kind of good because now they couldn't discriminate and women had some support for their activities. And all the time I was growing up, the fact that I still wanted to be physically active was, won't you ever grow up, Shirley? What's your problem? But now it was like, oh, that might be a good thing to do. And as I already mentioned, the MD referral became a prescription because they couldn't tell us what to do. And I wanted to highlight a few things about Medicare because I do think this is going to be issues for you ahead. So in 1962, 3 years before Medicare, only 1 out of 2 people that were over 65 had any kind of health insurance. And I remember my grandparents were amongst those people that did not. By 2013, and that's when these figures are from, only 2% of Americans over 65 did not have health coverage. And the thing I want to point out is that in 1970, the spending per beneficiary was $385. But by 2013, now that's 7 years ago, it was $12,200. Well, I wondered what $300 in 1970 meant in money of today. It means 2,000, not 12,000. So we're talking about 40 times more cost. And I can't imagine what that figure is today. And I think this is going to be a big issue for all of you. Already the life expectancy from 65 has increased by 10 years. There are now 56 million people on Medicare, 10 more million because they're disabled. And we know the percent of older people is going up. So I think that this is something that we're going to have to still be aware of. And we know from this attempt to cut our reimbursement by 9%, that's been reduced some, but with all the debt that's increasing now, I think we're going to have a big issue with reimbursement, which is going to speak to the changes that I'm recommending. So the highlights of these first 50 years from 21 to 72 is we have a profession, an association, we've got educational programs, improved standards, increased numbers of patients, particularly those with central nervous system lesions. The prescription became a referral, but we still needed to have the doctor send us and tell us what was wrong. We had increasing numbers of physical therapy jobs in hospitals and rehabilitation centers, and a growing emphasis on named treatment systems. It was getting bigger and bigger, and continuing ed was getting bigger. But there was still this prevailing belief that medical conditions were an acute condition and that treatment was given to them after they had the onset of their problem. Just this little hint of lifestyle. I was very, very fortunate because at Washington University was a physician. We were in the Department of Preventive Medicine, which was too far ahead of its time, named John Hollizy. And John was doing 2 translational research. He was showing how exercise and nutrition made a huge difference in health. And he ran rats and he also ran people and exercised them. And some of our faculty participated with that. It was a real eye-opener for me. I thought, you mean you didn't just get the diabetes, you didn't just get the hypertension? There was something you could do about it. That was amazing. So we go on from the middle 70s to the 80s, and profit got even better. We became really income producing. The manual therapy treatment systems became wider known in the United States and more emphasis on them. Career orientation seemed to grow, and we introduced specialization. And I don't have to tell you today how big the sections, which are now academies, are. In fact, the combined section meetings has grown to such an extent that there's no association meeting anymore because of the popularity of the academy meetings. And research was started, and it was beginning to take hold. But in the middle 1970s was also this call for needing to create an identity and a body of knowledge. So the details are, we're income producing, we've got more students, and those were having students come in that already had a degree, so they were older and more mature. And we had more physical therapy programs. NYU in New York sort of set the the way by developing and establishing a PhD in physical therapy. So we were thinking about advanced degrees in physical therapy. IFOP, the starting of the International Federation of Manual Physical Therapists, was an indication of how manual therapy had grown in popularity. To me, the really good news about manual therapy is physical therapists began to feel responsible for figuring out what was going on, at least what was the pathoanatomical problem. Sort of the downside from my perspective is it really decreased the emphasis on exercise. That wasn't an important part, particularly as it got started. And then in 75 was Public Law 91-142. And these were the services for children. It wasn't just that these services were there for children, but what it also mandated was direct access, because physical therapy and other providers could go in without requiring a doctor's referral, and we weren't competitive. And I know very well because I worked with a woman that got direct access for the state of Maryland, and actually in 1979, which was before it was ethical for us to practice with direct access. But it was an important step in being able to provide opportunities to deal with children. And then in 1975, Helen Hislop's often quoted Macmillan Address, and she mentioned pathokinesiology because she said, we are not seen as having an identity. We do not have a science that defines us. Specialization was officially started in 78. And then again, another very fortuitous thing for me is Steve Rose came to be the director of the physical therapy program at Washington University. And Steve was so prescient. In fact, all of these things that I'm so obsessed with were his ideas. And unfortunately, he left us too early to be able to continue to pursue them. He wanted to convert the faculty from school teachers to academics. He wanted to make research happen in large measure. And he was committed to classification. And he wanted to construct a curriculum built around pathokinesiology. Steve had all the right instincts and the ones that I think have laid a huge foundation for us from there. And we just need to keep moving in that direction. And then in 1979, this fund for physical therapy became the Foundation for Physical Therapy. And that was important because it provided research monies for physical therapy to be able to use. In the early 1980s, we'd lost some profit. And that was one, we were working on direct access. It became official. We said we need to change our entry level, but DRGs came in, diagnostic related groups. It was in this period that we also said, we're going to be diagnosticians. We have to make a diagnosis. So in the early 1980s, the specifics are, we officially made it ethical so we could practice with direct access. And actually there's some form in all states. It varies a great deal as to how much or how little, but it's still a very small percentage of the patients we see. In 1980, we said we need to go beyond the baccalaureate degree and we should be there by 1991. But by 1995, only one half of the programs were at the master's degree level. Now, I have a little comment about this too, because what we did was move them into the academic setting. We didn't move them in a way that was a professional degree, but an academic degree. And what that meant is that we had to do research, incorporate that into the program where they were in an academic setting. Last night, I listened to the interviews for the Neuro Academy, and Faye Horak was part of it, and Pam Duncan, and Ann Van Sant, and Don Newman. And I was so interested to hear these researchers say, they don't really think it's a good idea to require research in the academic setting for physical therapy entry-level education. Those that are interested should participate in faculty research. I personally do not believe there's enough time to learn how to be a physical therapist. I know you don't have enough time to be an investigator, to really do research. So I think that's something that people need to think about in their time devoted to honing the qualities and abilities of the physical therapist. About 1982, we began to work at a national level on a description of physical therapy. It was first approved as a philosophical statement, and we at last related physical therapy to movement-related conditions. But then in 1983 came DRGs, diagnostic related groups. And I'm sure, as all of you know, the hospital gets a set amount of money to take care of a specific condition. If they get the patient out early, they make money. If they stay too long, they lose money. The jobs went away in the hospitals. I remember Steve having to get rid of some of the therapists that were working in the hospital. Now, happily, there was a transition because all the patients left the hospital too. And then the irony was we found out they were healthier leaving the hospital sooner than staying around a long time. But it kind of shifted to increased outpatient services and home health over a period of time. So we had a little down thing. And I really think, just for perspective, you ought to know that in the middle 1980s, the average physical therapist brought into the hospital $300,000, and our salaries were $30,000. So we were a big income producer. We took care of the laundry, the dispatch service, et cetera. So that was a real blow to the profession for a period of time. It was in 1984 that there was the official statement in the House of Delegates that we must establish a diagnosis. It's 36 years later. We have many documents that say we have to make a diagnosis, but I have yet to see what diagnosis we make. There is no description of the diagnosis we make. So the growth of PT had been accelerated by this source of income from Medicare. And one of the ways that they had to pay for procedures, at that time, the patients received all the modalities. I'll never forget looking at, I finally got a referral one time that said no more ultrasound. And because the patients got ultrasound, e-stim, hot packs, et cetera. And not until the insurance carriers caught on and they started paying per visit instead of per procedure. But we were going big time. So the late 80s to late 90s, increased research, the profession was growing, it was moving on. Advanced entry level was growing. The doctoral degree came into existence. We had increased jobs, increased students, and increased school. But then came the fly in the ointment, the Balanced Budget Act. And now profits went down substantially and students went down. So let's look at the details of this. In the late 80s through the 90s, the events were, the one good event, again, was lifestyle was beginning to be recognized more as a factor in health. There was increased recognition. And lo, would you believe it? We found out that exercise really can make you healthy. It's like really important. There was also, and I know people don't think about this very much, but there was also a symposium on pathokinesiology. Steve was very head up about trying to get science behind the profession. And so he had organized a symposium, and then there was a publication in the PTJ, and Jules Rothstein was the editor at the time. And I'm going to switch to what Jules had to say as he introduced this special issue. And this was in 1986. And though he says that he has a question mark, a name for our time, he said the introduction, this was an introduction to this special symposium. And he's saying the identity crisis Hislop saw a decade ago has worsened. We as a profession may be doing more things, but in no way have we developed a true sense of who and what we are. We're defined by the tasks we do, and as a result, only if you've seen a therapist in practice do you have a notion about what we are. I'm still worried about this, even though we now have an identity. So the other thing that happened that really was a help to us is that NIH established the National Center for Medical Rehabilitation and Research. So there were research funds. They were really intended for the doctors of physical medicine to use, but the PT stepped in and actually have sort of taken over all of these funds and probably have the biggest percent of grants from this particular institute. And what it also did was not only provide research for physical therapists, but it also was a way that we could support PhD programs, which is what we did. In '93, Creighton started a DPT program and their graduates were in '96. This really spurred development of DPT programs. It wasn't such a big deal to say I have a master's degree, but it's a really big deal to say I am a doctor. I have a doctorate. I was super supportive of this move myself because I also believe that students coming into a program that say, I want to be a doctor already indicates they want to accept more responsibility. The Guide to Physical Therapy Practice was published, And it attempted to address several factors, and we'll look at that in just a minute. And these students, mostly of them were already entering with BS degrees. They were career-oriented, and they started to have sports backgrounds. More and more things were going to musculoskeletal. So they were growing in numbers, and programs were growing in numbers. More faculty had PhDs. It was getting to be a requirement you had to have a PhD. And practice, as I said, was really becoming more income producing and related to musculoskeletal problems. The rehab length of stay was getting decreased. It was pretty interesting to me because I was looking at some figures. When I first started, the spinal cord injured would be in the hospital. They could be in the hospital 9 months to a year in some places. Now it's 1 month. It's pretty amazing. And it's going to cost $1 million to take care of them. But here came the big fly in this ointment, and that was the Balanced Budget Act of 1997. This cap on Medicare. And worse for us in physical therapy was that we had to split it with speech. So the ongoing statement was, do you want to walk or talk? OT had the whole money to themselves. So jobs really decreased, salaries were cut, student applicants went down substantially, and classes weren't full as they had been before. And in some ways, it was a perfect storm because we had more educational programs, we had more students coming out, and we had more foreign trade coming in. And then all of a sudden, all the opportunities went away because of this cap set on the amount of money that could be spent on Medicare patients. Oh, I want to just take a minute to talk about the Guide to Physical Therapist Practice, because its intention, and there had been many books, there was a red book before this and several other things trying to say, this is what physical therapists do. And I think in some ways it was also a little bit to address the issue of diagnosis. And it wanted to facilitate the development of preferred practice patterns, probably what's known as CPGs these days, to reduce unwarranted variation in provision of treatments. And I think variation is a huge problem in our profession. There's too much variation. Improve the quality of physical therapy practice, of course, enhance consumer satisfaction, appropriate utilization of healthcare services, and reduce costs, all worthwhile goals. So moving on to the highlights of the 30 years from the 70s to the 20s is Medicare was great because it made us profitable and it increased jobs, it was behind growth. The DRGs was a little decrease in the profit side of things, and the Balanced Budget Act hit us really below the belt. The increased numbers of students we had competitive PT admissions, and more faculty had graduate degrees, as did the students coming in. The entry level was changed to beyond the baccalaureate level. The faculty was now becoming academics and school teachers. Research was being emphasized in practice. Specialization was taking off. The shift in patient conditions, again, mainly from not neurological to musculoskeletal, because joint replacements, joint surgery, radiology to say you're falling apart. We could find out all these bad things that were going on with our radiology. The pursuit of direct access, and that we should make a diagnosis. And growing recognition of lifestyle as a factor in health conditions. And I think also the first real inklings that these were chronic diseases, not acute problems, but chronic diseases and related to lifestyle. And so we move up to the 2000s to 2010s, and profits started going up again. We're defining practitioner goals with our vision statement of 2000 for what we were going to be in 2020, and we're here, people. In fact, we're past 2020 now. Increased our entry level to the DPT programs. We've got residencies and fellowships, and pretty much recovery from the Balanced Budget Act. And the vision statement, I think, was really good because it said what we need to do is have continuous responsibility for the patient, not an episode of care, not stop in and then go away forever. Direct access, evidence-based practice. We really started trying to put an emphasis on this evidence thing. And professionalism, be a doctoring profession. And autonomous practice, which means really assume the whole thing, not just come in without the referral first, but assume the total responsibility, and that should include wellness and prevention, and that we are the practitioner of choice. The entry level DPT had gone from 19 to 74 by 2008. They expected by 2008 to be 150. Of course, now we know it's bigger than that. and it had a big effect on the student applicants. And I think the other really important thing is we went to the transition DPT or the post-professional. We allowed people, we set up ways so that people were out there without their doctorate degree could get doctorate degrees. And that was really good because it got people back to the literature and critical thinking. I remember having one student who came in for the post-professional program. And she said, you know, I've been out here for 12 years and I've never looked at the literature. Oh, well, that's nice. But it was harder then. You had to go to the library, you had to drive, you had to go through the stacks to find something. But by this time, you could sit on your computer in your PJs if you wanted with your coffee. Increased direct access, 38 states by this time. And we were pretty much by 2007 recovered from the Balanced Budget Act. But there was getting to be a bigger limitation on stay at rehabilitation centers. And I think only 20% of people that were paralyzed really got into rehab centers. So by 2010 to 20, we had a little bit of a downswing in the profits. And I don't know whether you can see this, but I also have this issue about quality, because I think quality is starting to go down. And one of the reasons is, and what I have there, it's productivity. There's a big emphasis on productivity. And I think one of the tricks we have is how do we stay profitable with high quality? And I'm going to suggest to you that having diagnostic labels will help. And we're saying DPT only. We have a scope of practice and we had a movement system summit. So here are these events. The new vision, instead of what the practitioner is going to be, it's what this practitioner now can do for society to enhance the human experience by optimizing movement. Direct access in all the states by 15. In the House of Delegates, there was a motion, and I know Steve was playing a role in this, that requires development of movement system diagnosis. So in 16, we had a summit, a movement system summit. And there were initial recommendations that we have a definition of this movement system, which was also I claimed to be our identity. Finally, from 1975, we've now got an identity. We didn't want to rush into anything. We said we need a little, I'm calling it an intake exam. I think it's called a screening exam, whatever, a little exam that looks at how people are moving, so then you can move on and get more specific, and that we should have diagnoses that are movement related. We said that entry level has to be at the DPT, and we have a scope of practice that we'll talk about in just a minute, an outcomes registry to show that we're being effective and hopefully doing it for less cost. Our membership is now at more than 100,000, and we have a new mission statement. And then in 2019, a definition of the movement system, the integration of body systems that generate and maintain movement at all levels of body function. And what I have there is the graphic from the APTA of the movement system. So the scope of practice says that it consists of a patient and client management, which includes diagnosis and prognosis to optimize physical function, movement, performance, health, quality of life, and well-being across the lifespan. And how are we doing that? In addition, the professional scope includes contributions to public health services aimed at improving population health and the human experience. How are we doing that? Jurisdictionally, you have to practice like your practice acts, and personally, activities for which a physical therapist is educated, trained, and competent to perform. And our mission statement says that our association, our community of the APTA is advancing the profession of the physical therapy to improve the health of society. And that is integrated with the vision statement of improving the human experience. And that we're an outward facing organization. And so it's telling us how we're going to and what we need to do for society. So the highlights of these 20 years is this outward looking vision statement, getting the kind of practitioner that we need. We have specialization, we have an identity. We've had a summit that talks about the content of that system. We say we're movement experts, doctoral only, entry level. And my big concern is we say that, but I do not believe anyone looks at our students as doctors. That's got to change. We have increased membership. We've recovered from the Balanced Budget Act, direct access, And I think this is what's so important, and we have to relate more and more to it. Health conditions are chronic. They're related to lifestyle. Physical activity is one of the best treatments. I always like to say, if it came in a pill, we'd be on it 3 times a day. Now, sadly, people are working on a pill to replace physical exercise, which is just horrible in my mind. So my summary of this amazing journey is the membership of the APTA is now 100,000. But I looked on the Department of Labor statistics. You know, there are really 235,000 physical therapists out there that they say are active. We have about 252 PT programs. We've got PhD programs in related sciences. We've got great potential for more growth. We've got this professional doctorate degree and more people that are oriented as being career professionals. Faculty have academic and professional doctorate degrees. They participate in research and practice. They have NIH funding as well as foundation funding. We have a vision with a practitioner that's accomplished almost all of that vision for the practitioner, and the new one that's outward looking. We've identified our expertise in a physiological body system, and we've pursued recognition as movement experts and diagnosticians. But the barriers, and one of those is tradition. Establishing and sustaining previously that from external perceptions that another health practitioner is required to initiate treatment and approve the plan. Another healthcare practitioner is expected to diagnose the problem needing treatment. That we're there for medically necessitated conditions, not so much for wellness and prevention. I know, unfortunately, if somebody wants an exercise program, they go to a personal trainer, a yoga teacher, a Pilates teacher, not a physical therapist. We're using treatment based on named identified systems, further promoting what we do and not what we know. And I think, unfortunately, it's put less emphasis on applying the knowledge of the basics of anatomy and kinesiology. We use physical therapy as a generic term, which further contributes to the belief it's rather simplistic. We don't tell them exactly what we do in physical therapy. We just say physical therapy. It either cures you or it doesn't. External stakeholders lack an understanding of the complexity and of optimal movement and exercise. We've made it seem simple instead of the complexity that it really is. And internally, we still discharge patients rather than ending an episode of care and provide ongoing monitoring and continuity through the lifespan. We claim movement expertise, but we don't delineate the specific abilities and responsibilities. We claim to be diagnosticians, but we don't have any designated professional labels related to the movement system or identity. We emphasize expertise in treatment systems rather than how the treatment addresses the problem. We fail to emphasize the relationship between movement-related impairments and treatment strategies and the prognosis for functional performance. And we're not clarifying whether the treatment is for symptoms, manifestations of a system pathology, or cause. And there are many ways in which we treat cause. So I want to talk about some specific, filling in the details. We can't say we've got abilities unless we fill in the details and demonstrate. I am so happy when I see that a physical therapy service is doing running assessments, biking assessments, looking at tennis players. We've got to look at how they perform their activity, what adaptive patterns are taking place, gymnastics, dance, musicians. I remember so well having professional violinist players and going between the physicians to clarify whether the problem was from the cervical spine or the shoulder. And they went back and forth and we could sort it out. I picked out this golf guy because he ought to have back pain the way he's swinging that club. These are things that we've got to make people know that we can figure out. We don't have to take over their coaching job, but we have to figure out what that person needs. And I picked out this guy. I guess you can figure out who he is. You can kind of see his name. And I'm circling his shoulders because if you follow the shoulders, they look very different. The right one's sitting much closer to the water. It's tilted forward, and the left one isn't. And in this view, you can see very well, this one's still standing up. This is forward. This is hitting the water. This isn't, not at the same place. And so how is he treated? By cupping. Well, now he's got evidence that he's been treated. But how did we know that the right shoulder was going to go bad? It was pretty easy looking at him. Of course it did. So there it is. That's the treatment. I don't know that he had physical therapy as such. And then this girl, she's a gymnast. And I've taught enough continuing education courses that I know if I said to the therapist, so which abdominal muscle needs work? very often I get the transversus, and I just think you ought to know that the transversus really only suffices for all the abdominal muscles in Australia, and that's because it and Australia are both down under. But anyway, so what's the best exercise for her? Any of these ones that are demonstrated here? No, none of them. And then this little girl was good and lucky enough that even though she didn't have pain yet, she wasn't able to perform when she changed ballet schools. So she got in the hands of a physical therapist that knew ballet and who worked with her, so that now she not only could perform in this new school, but she could also win prizes there. And what I've tried to highlight is Linda Van Dillen has just published a very important paper in JAMA that cites how training people how to using a motor learning strategy to change how people do their functional activities is the most effective way of dealing with back pain. It's compared to strengthening and stretching. People get better. Anything you do to them makes them better. The question is for how long and to what extent. And Linda has shown very clearly that it's a big extent if you change the way they do their everyday activities, best yet with a motor learning thing. And I put on, is there enough emphasis? Do people really understand this girl doesn't have gluteal muscles because her line of gravity is so far behind her hip joint? Do they know in this ultra marathonist that his abdominals are what's pulling him into a thoracic kyphosis? And that this man with his shoulders behind his line of gravity is really making his abdominal muscles his anti-gravity muscle and furthering the overdevelopment of those muscles? How much are people thinking through these biomechanics and muscle adaptations? And then we're the ones that need to see everybody. What about structural variations? These two young boys had mirror image femoral anteversion. They played soccer and their coach was vigorously trying to get their knees down to the floor because his interpretation was their adductors were too short. Well, happily, we got to them before they had injured their hips completely. This girl has femoral anteversion and she was a ballet dancer. I don't know whether you can see it with the pictures here, but she has excessive tibial femoral rotation. If you have femoral retroversion, you can't do squats with your feet straight ahead. We need to be identifying these things and helping people to pick the right activity in the right way. They can go to their personal trainer, they can go to their coach, but they need the guidelines from a physical therapist. They need to be seen yearly. And this girl with her nice kyphosis and her increased lumbar curve and her pain, and she was doing this exercise. Could this have had anything to do with that kind of alignment changes in the instead of her pain? I kind of think so. And then I just picked these pictures off the internet just to make the point. No young people should be sitting in these chairs working their legs because that takes the trunk muscle participation away. Worse yet, this should be recumbent for him. Is this helping his abdominals? No, but it's going to make his pec muscles shorter and it'll make his abdominals even longer. Every one of these kids needs to be looked at because in the bottom picture, because they're certainly not doing their motion correctly. And none of these young men are in the right alignment. And you can just see the discoordination. These basic skills we should be helping people with. We should be lifespan practitioners so they can exercise and not get hurt. So the next steps in our journey to an accurate perceptions and new traditions: promote the importance of the movement system in wellness and prevention, expand the business model, encourage research and dissemination of information about the role of movement in pathology. Pathokinesiology is how a pathology in a contributing system causes a movement problem. But kinesiopathology says how movement causes and contributes to pathology. We can be there, we can do that. Clarify how the profession's body of knowledge is complementary rather than competitive with other healthcare practitioners. We can refer patients to doctors, and that our body of knowledge is movement science, and our practice science and our practice system is the movement system. We can promote the expertise required of a professional responsible for the movement system. Have a general intake screening exam, looking at basic movement performance. Clarify the complexity of exercise and what it takes to prevent injury. This, I keep saying it, but it's so important. Ongoing monitor through the lifespan. Develop, implement, and disseminate movement-related movement system diagnosis, emphasizing that treatments based on the underlying movement condition and contributing factors. You know, this is the way we can increase efficiency. Studies have shown that to get a working diagnosis takes 60 seconds because it's pattern recognition. Diagnosis explain patterns. That's what makes us efficient. And if something doesn't fit a pattern, then we've got a new condition to figure out. And I'm going to be really a bit radical because it doesn't matter anymore. I don't need my job. It's over with. I think we need to change our title. I think we need to eliminate therapist. The title therapist says that somebody else figures out the problem and you apply the treatment. Speech has done this. They're not speech therapists anymore. They're speech and language pathologists. And they didn't even change their educational level. We've changed our educational level, but not our title. We don't have to change the name of the profession. We don't have to change the DPT designation. Neurologists are still medical doctors. This is consistent with being a doctor with expertise in a body system. Who can diagnose and develop a plan of care, who can guide and enable prevention, who can develop a program of physical activity that builds health without injury. It would be called personalized therapy, just like they're going to personalized medicine now. It's all about personalized medicine. Let's be personalized therapy. Let's expand the business model to autonomous practice and cash pay with gyms and personal trainers that you employ so they don't undo all the things that you've done. And again, this whole monitoring. Let's fill in the details and demonstrate those abilities. CDC advertises the health benefits of physical activity, lowers your cancer risk, even helps with dementia. I really believe that we can be the profession that slows down the onset of arthritis. And someone at the age I am, I can tell you, you'd rather get it at 80 than at 50, because it's not fun at 80. We need to go beyond declaring expertise. We need to fill in the details so that profit and quality both go up. We need the recognition and respect for doctors who optimize the development and health of the movement system, and when necessary, make a movement system diagnosis. So in the next 100 years, when I've gone off to the great plinth in the sky, I can be well assured that this beloved profession is transforming the health of society by optimizing movement. So thank you for letting me share these thoughts. I want to thank Susie Dusinger, Dr. Dusinger, for helping me clarify some thoughts and translate some of this Sarmannese to English. And she's been a great big help, and I want to thank her very much. So thank you very much.
Thanks so much, Shirley. And hopefully you can see the clapping hands. I wish I had a sound effect on here for the applause.
Oh, I hope so. Thank you.
But
Thank you.
but we're seeing many claps. I think we do have some time. Shirley's left some time here for
Great.
questions and discussion. And please unmute and ask questions, or you can type them in the chat.
Nobody wants to ask anything? I've answered all the questions. Or it's time to wake them up, or
Could I say something?
Sure, Jay.
Yeah, I don't.
Today you don't.
It's so nice seeing you, Shirley. I haven't seen you in a long time, and I really appreciate you taking the time and to put this all together. It was just a wonderful talk, and I just wanted to mention. I'll be very short. I remember when I was in physical therapy school back in '83, and you told the story about when you went to, I think, your first APTA conference or some early conference, and you were sitting in the lobby and you didn't really know anybody there, and you somebody walked through the lobby with some kind of gait deficit, like it was, but you watched the person for a second and then you started looking around the room to see who else was watching them, and that's how you found out who who is part of the conference.
Exactly. Very good, Jay.
Yeah.
Yes.
Yeah, so I could tell a lot of stories about you, Shirley, but I'm not going to do that
No,
now.
no, let's not. Let's
I
not.
love you. I really appreciate what you
Thank you. You too, Jay.
did tonight. And I'd say that, and I love you a lot. Take care.
You too.
Shirley, a question in the chat from a few folks is, if you had to rename us, what would it be?
My suggestion is something like movementologist. I would like to tie movement into it, and I think ologist is important. I'm not committed to anything in particular. The speech people did pathology, speech and language pathologist, and I don't think that would be a good idea because it puts you already into pathology. I think it's got to be something that's neutral, because as I've tried to convey, I really believe our place is in prevention. And so I wouldn't want to be tied to a pathology type of thing. But if there's a way to work out ologist, because it means the study of, and it helps to talk to your specialty, like neurologist, cardiologist, ophthalmologist, etc. So something along that line. But I really hope you people will move that along. It would be rather painless, and it's so easy. And I think so essential, because they're, you know, I've seen in hospital brochures that we're linked with movement people, with musician therapy and other kinds of strange therapy, because we're therapists, and we're really not therapists. You're doctors now, and you don't want to be labeled a therapist.
Shirley, a question from Cameron. With all the different approaches, methodologies out there, how do you best see us coming together as a profession to unify diagnostic or classification systems?
There really shouldn't be any conflict, because the idea is not that there aren't all these different ways to treat people. The important thing is to put the label in so that you know what's the most effective treatment to move along with. I think the big problem is that we're all about just doing a treatment without thinking about what the primary problem really is. And so I'm not trying to, there's no intent on my part to negate the advantage of knowing different treatment techniques. But just like with physicians, they have different procedures, but it all falls under the heading of a specific diagnostic entity. And I'm not, also, just to be sure, because this keeps coming up, I am not pushing that everybody has to make a movement system impairment diagnosis, not at all. I think it needs to be a movement system diagnosis, but the APTA had 90 submitted, but they're sitting in a stalled, forgotten bin, and they're not moving it along. And I'm just concerned that we can't wait another 34 years. In every document, it says we're diagnosticians. And I can just imagine going to a doctor and say, well, doctor, what's my diagnosis? Well, we don't have any labels, but I know I've diagnosed your condition. What a joke.
Good evening, Shirley. I had a question regards the comments pertaining to the consolidations of physical therapy vis-a-vis private practices. As you see, that is a number of, a majority of private practices are held by a very few organizations across the country, and they seem to be growing.
Yep.
That seems to have a direct impact on the minimizations of the effectiveness and sort of, really the reputation of good physical therapy.
I agree.
Any words of wisdom for a number of the sort of young and up and coming physical therapists as they're at that crossroads, as they're whether to go with the big practices, strive off on their own, etc.?
I don't. I mean, I've been I'm kind of a cop out, because I've always been in an academic setting, and that's a lot easier. No, I mean, even physicians, as you know, are in large groups now. It's not just physical therapy that's in trouble. And when I get my Medicare bills, I certainly see why. But I don't know. I think that if we as physical therapists can just make a case that we can do more, and I think we'll have to work through the large organizations to be able to convey that. I think that physical therapy services need to include gyms. I think they need to offer everything there is to offer and bring patients in that way. Offer Pilates, offer yoga, have the trainers trained, etc., and offer running clinics so that they're big expanses. And I think even if you work through a large corporation, that these would be ways to bring it about and still let it known about what kind of expertise you have. And maybe there's a way that you come in and I was thinking about this and I don't know all the ins and outs, but that if the person wants, I know people that have expertise in gymnastics and they could only see the patient and treat the pain and not look at their gymnastics performance. Maybe you could say, well, if you want to come back for a cash pay visit, then I can look at your performance and make particular suggestions to you. I don't know because I haven't been out there, but I'm sure there are people a lot smarter and more educated in these ways that can come up with ideas. But we've got to come up with them. Otherwise, we're going to be replaced by our local chiropractic school is offering master's degree in sports training, and they're going to fill the gap. They're going to try and fill the gap if we don't get out there.
Shirley, before the next question, could you stop your screen share?
Oh, sure,
And,
sure.
we'll all be able to see each other a little bit better. Thank you, Tammy. And we've still got a few more minutes here.
Okay, great. Anybody else? Are there any questions in chat?
Well, Shirley, there's a couple other name suggestions.
Oh, okay, good. I'm for any kind of name. I'm not committed to anything.
I don't see any other questions right now in the chat.
I see there are 31 items.
Well, there's a whole lot of thank yous.
Oh, well, that's nice. Oh, I'm glad to hear that. I'm glad to hear that. It's very difficult when you can't see faces.
So Shirley, thank you for an inspiring talk. I really appreciated it. I guess my question to you, and maybe it's been asked in a couple of different ways, but what are our next steps as we look forward into the next 100 years, and what do we have to do to make it a priority? I mean, we've heard over many years that diagnosis and movement, and it seems like we have great talk, but we never have the follow-up action that's needed. And I don't know if I struggle with, is this because it's not valued at the grassroots, or we're just not reaching the audiences that we need to create the change? And I didn't know if you had any thoughts on how do we create that change?
Well, I mean, actually, Tammy, that's exactly the heart of what I was trying to present here. We make these declarations. We're movement experts, but what haven't we done? We haven't defined what a movement expert is. And I know very well that there's a big decrease in the emphasis on kinesiology and biomechanics. Well, that's critical to knowing what's going on with a patient. So we're not fulfilling that. We go on to more, we've always been a profession that jumps on the latest thing. So, we had Pilates was our big thing, and everybody had to get a Pilates training. We need to fill in the details. That's why I'm harping so much on diagnosis, because if we really try to center ourselves on understanding the problem, and people have to do that, then we can look at the best techniques. Things will fall out to help with that problem. It would reduce the variations in practice. If we spell out what it really means to be a movement expert, if we have an exam that everybody has to follow through on, and they have to sort of demonstrate their understanding of that, rather than saying, oh, we're movement experts, but I don't know what one really looks like or what the criteria are. So I think rather than going off after more fancy things, we need to shore up. I do believe, as I said during this presentation, I've taught enough continuing education courses, and I know that people don't have a clue as to what the differential functions are of the abdominal muscles. Nevertheless, a well-designed exercise I was going through looking at pictures on the internet. I don't think I'll be able to sleep tonight. I had nightmares looking at the suggestions that are out there. But that's what people go to get, and they don't think to come to a physical therapist to get this. So I have to think we really need to hone in on advertising what we're special at, instead of here's the new trick that we're going down. You know, we floss nerves, we do all kinds of funny things, but we never say this is what this patient needs, and this is what I do well. So that's what I think we need to look at that. I think we need to really establish this and have the time to do it. And I think we're in this pressure because there's decreasing, this productivity things going up, and people are barely getting examined, and then they're going out and riding a bicycle around for 10 minutes before they start their program. So it's getting too generic and not specific, and there's a lack of understanding of the basics of anatomy, kinesiology, and application. I don't know, is that an answer to you?
You know, Shirley, just to kind of follow up on your point, so in the practices that I manage, a lot of that instruction happens after we've hired therapists to train them how to communicate, with their patients, with the community, and educate what a physical therapy truly can do. But I think some of that should be done at the educational level, because by the time we get them, you know, it's literally, we're looking at the types of terminology to be used, looking how to engage a young athlete, whether it be a gymnast, as you said, or somebody who's doing yoga or a marathon running. They know the anatomy, they know what to do. They don't know how to explain it to that patient and show them that it's better to see me and work with me as opposed to a trainer, or I can work with your trainer to help facilitate and expand upon what you're doing.
You know, again, and let me just get in here to make the point. Your point is so good, because one of the things is people do not graduate from physical therapy school knowing a basic exam. When I ask around, when you graduated, did you have an exam that you will do on every patient that has low back pain? There's no such thing as a systematic exam that people perform. And it doesn't mean they can't change it once they get out there. But if they have an exam, it's special tests. And then, like, what are you going to do with a special test? I didn't know you operated. I mean, it's not anything. And I think that's really important, that they be able to hit the ground running. And if there's a modification, and I know these large corporations are working hard to try to reduce the variation in practice, because I know that's one of Patty Sheets' job. And I've heard this presentation at CSM and next about that. So you're quite right. You have to start getting the therapist to, I'm sorry, my phone's ringing, to have more skills when they leave school. And I don't think that's what's happening. They can have a basic exam that they need, and that they've been tested on and timed as well, because many people go out there and they maybe only have 30 minutes to do an exam. Well, you can't do much, particularly if you're figuring it out along the way. if at least you had a diagnosis and pattern recognition and some systematic exam, you'd be able to get started. So
Shirley, there are a couple more questions in the chat. One question from Kathy: could you speak to the role of the PTA in care of patients, and maybe Shirley, within the context of what sort of talking about our future?
Well, I do think that the PTA, I think that the physical therapist can implement, need to design the program, get the diagnosis, and then the PTA can help implement it once the patient's gotten started. They should be able to do things well beyond what a personal trainer would do. I also believe that we are going to have more quantitative tests, and I think the PTA should do the quantitative tests for us. I remember when the PTA first came in and they wouldn't let them do anything that was an examination, because then you couldn't tell them from a physical therapist. I thought that is so sad that a PTA can't measure range of motion or do other things because that would make them a physical therapist. It sort of said, that's not what a physical therapist, what are they about? And so I think all of these kinds of measuring things, I can guesstimate the amount of range of motion, but the PTA could be able to actually measure it themselves. I think they should be able to supervise the exercise program that the PT has designed. and know what it should be, but not design it themselves or take them through a simplistic program of some sort.
Thanks, Shirley. And from Megan, what do you think about us stepping into the role of primary care with regards to yearly checkups? The PCPs are overwhelmed with new patients and follow-ups.
You know, to tell you the truth, they have advanced care practitioners that are in England and other places. I really am not keen about that. I think the reason why is what they're doing is they still have to refer out to a physical therapist. It's like an initial screening. And I don't want to be a physician assistant, and I don't think we should be physician assistants. And I can tell you, like, one of the things that we offer is the physical exam. And when you're like my age, I just had a skeletal exam. I have arthritis and everything. So when I have a pain, who knows where's it coming from? It's why I always tell the story. My uncle got a new knee for spinal stenosis because he had pain in his knee and his knee was worn out. So they put him in a new knee, but he still has spinal stenosis. I had to figure it out. So you could replace, if he would have gone to a hip doctor, he would have gotten a new one of those too. We're the ones that do the exam. Physicians aren't doing it anymore. I don't want to be a physician. I want to be a therapist that does a physical exam and helps people to sort out where's that pain coming from and what can you do about it. That's why you got to look at these as chronic problems. So I'm not personally keen on advanced practitioners. I have a very good friend in England that is one, and he has to refer out to physical therapy. It's just a way of saying another kind of physician assistant. Yep. So what do I really think?
Well, Shirley, I wanted to ask you, you went through a number of changes in our healthcare system in your presentation that seem to guide a lot of other things or modify a lot of other things, like reduction in payment and reduction in ability to treat people. Where do you think we're going next there? What's the next big change in healthcare policy?
Oh, I think we're going to have something that's akin to the Balanced Budget Act. I just don't see how we can have trillions of dollars of debt. We're going to spend, I'm not, well, we're going to have more expenditure because of this pandemic and our economic situation. I don't think there's any doubt about it. They're going to have to cut costs. And we're seen as quality of life people, not quantity of life people. So if anything's going to go, it's people like ourselves. And that's why I think we need to change our business model more to a cash pay model. But we got to demonstrate that we have something to offer that other people that they pay cash to, that we have more to demonstrate than those people have. And sort of the way reimbursement was when I stopped practicing 8 years ago now, the copay was going up and the reimbursement from the insurance company was going down already. So I just think we have to make such a strong case for ourselves that people are willing to pay out of pocket to come and see us. We can't see them 3 times a week on that basis, nor should we, but we can see them periodically and make more money because we don't have to spend half of it to collect. We'd just be right there. They do it for trainers, they do it for masseuse, but they don't do it for physical therapists very well because we haven't made a case for ourselves. I think, in Australia, they have more direct access. I think it's still only about 50% of the people, and people pay out of pocket. They don't pay that much, but they think about if they have a pain problem, they go to a physio. That's because they didn't have traditions before. That's why breaking that tradition, and that's why, again, I'm all for changing our name. We've got to do lots of things that say we're a different species now, and that we're not playing by old rules or old standards.
Well, Shirley, when we draft the change, we'll be sure to use species in the rationale. I think that's a good way to put it. We're at the 6:45 time, and I think if you have a beverage with you, please prepare that. There's Tammy, and
Actually, unfortunately, I had to give up drinking because of my my health conditions, but
Well,
but
Shirley,
I get a high now without alcohol.
Shirley, in all seriousness, thanks so much for doing this. It really was a wonderful evening and a lot of
Thank
things
you.
to think about. And we'll say happy birthday to APTA one more time. Thanks again.
Very good. Thank you very much. I enjoyed it. I hope we gave you some things to think about. Thank you. Thank you, Jay. Good to see you. Good to see everybody.
Cheers, everyone. Have a great weekend.
Thank you. Thank you, Carol.
Thank you, Shirley.